Great, thanks for the great panel, very interesting. So in terms of student, and I'm a student, and I see this, the entrenchment of the current system in this strict boundaries, and especially in the big, well-established places where you have this professional identities formed throughout the years, and school of nursing is separate from the school of medicine, and all the schools are separated, and that's one of the big topics in this forum. So how do you see what's the role of students? And we all see this these boundaries, and we all try to think about breaking them. But how do you really see what's the role of the student, and what is the next step for the students to kind of to take it step further even, and to really build this partnership between the different organizations within the strict boundaries that exist today? Thanks.
I can jump in for that. So I think my advice, being not that far removed from being a student, is to never sell yourself short. And I would maybe just give the example of what happened at Harvard when I was training at one of the Harvard-affiliated hospitals, where I think we struggled with a lot of what you're describing with respect to both feeling that there should be more crossing of boundaries, but not knowing exactly how to actualize that. And some of the residents actually at the hospital where I trained formed a nonprofit organization known as Primary Care Progress, which some people may have heard of, which really just started a dialogue at Harvard Medical School about what should be done with respect to Harvard's role in primary care, Harvard's role in training primary care docs, and in institutionalizing some of the momentum that was coming from the bottom up and being generated by students. And so, as a result of Primary Care Progress really agitating along those lines, there was a Center for Primary Care that was chartered at Harvard 2 years ago with an initial $10 million endowment. And so I think that's a shining example, and certainly not not every student group is going to be able to pull that off. But I think there's a lot of power in students banding together and making their voices heard.
Thank you, Sandeep, and the panel, and especially for your question. Is this a movement, professionalism, and is there hope in the future for interprofessional and transdisciplinary practice? And, although that's a great question, whether you ask it or not, it's being answered, screamed at by the public. When I read The Bitter Pill in Time magazine from front to cover, when my 76-year-old mother, who's had multiple sclerosis since the age of 30, sends me yet another article about medical error, physician error, and it's not just physician error, it's a system problem. Or when the LA Times writes about the nurses, Board of Registered Nursing in California, and that there's just not enough policing so that nurses that are substance abuse users are still in practice and causing harm. I mean, the list goes on and on. The public is screaming for safety and higher quality and accountability and reduced cost. So I think whether we ask that question or not, we're going to get the answer from many different venues. And I know that those of us who care and are altruistic and have those competencies for good professionalism have been doing that to ourselves and in our profession since we read To Err is Human. So although we can't totally randomize and double blind a study on interprofessional practice, I kind of like to use that as a paradigm, because when you get really great outcomes in the experimental group, it's, the moral thing to do to stop the experiment and put everyone on the treatment. I think that we've been starting to see positive results in quality and safety due to interprofessional practice. And so I think it's a moral imperative, and I know those of us in the room are here because we all feel this way. We have a moral imperative to really change culture so that interprofessional education and practice becomes the new institutionalized norm. So thank you.
I've been trying to put some pieces together from our earlier discussion in the small groups and what the panel has offered. And actually, I want to wind up by asking Seyoun a particular question about his experience. But I wanted to start from a piece that we talked about in our workshop, which is that patients and families and communities are not seen as stakeholders in this discussion. And then linking to Judy's comment about the appellation apathy. I'm old enough to remember other labels that we've provided for patients, like the difficult patient, the crock. I mean, we have a long history in the professions of dismissing the people we service and care for if they don't fit within our framework. The flip side of appellation apathy is cultural humility. And South Central Foundation in Alaska imbues the notion of cultural humility into their orientation for all new care providers. And I think somewhere between appellation apathy and cultural humility, we've got the problem of a lack of a common language. How do we bridge that gap? I mean, that your mom doesn't understand what transdisciplinary professionalism is. I bet she would understand if we used a different language to describe what we're trying to achieve. And so, you know, that gets to population health, because this is all a population discussion. Appellation apathy describes a whole population, right? Cultural humility is directed at a whole population. So that then gets me to Seyoun and the question of, from an American perspective, we have the luxury of not shortages, but in many ways, too many health professionals. So what can we learn from what we would label as under-resourced countries where the shortages are much greater, and to ask Seyoun what he thinks his experience would be if he tried to do what he did in Kenya, in America. Would we have responded to a patient/lawyer trying to organize a national registry in the United States?
That's a very easy question to answer. What would the experience be like? Because I tried to replicate this registry idea or donor drives in the United States. I organized the first ever bone marrow drive in Nigeria. I flew into the Nigeria Law School on the final day of classes and just spoke for about 5 minutes. I told them that I had cancer and that I needed a bone marrow transplant. And because of genetics, the highest likelihood of finding a donor would be within my own ethnic group. And we had virtually 100% participation of the student body. I mean, these are students who, before my arrival, most likely had never heard of the concept of a stem cell transplant. They had received no advanced publicity. This was just a fly-by-wire operation, and it was wildly successful. By contrast, at the same time, we were organizing a bone marrow drive in New York City. We had organizations, there was a very powerful donor recruitment network called DKMS. They had brought in some celebrities like Rihanna and Justin Chambers to do PSAs. We had bombarded the airways, newspapers. We handed out cards on Broadway, everything we could to publicize the event. And we had fewer donors in the United States from weeks and weeks of publicity than we did from a 5-minute speech in Nigeria. And I think a lot of that does highlight the importance of culture when you talk about a social contract. For me to go to Africa and say I've flown halfway around the world to make an appeal to you as countrymen, as fellow Nigerians, as people who could possibly be the only ones to save my life, I think that took the concept of becoming a donor out of the realm of ideation and made it imperative. And it lent a certain urgency to it. And that kind of brings me to a related point. When we talk about contracts, as lawyers, any lawyer will tell you, a contract isn't worth the paper it's written on unless it is supported by consideration. Each party must give something and get something in return for a contract to be judged valid. So as long as in our minds, even if it's subconsciously, we're thinking of contracts in terms of altruism, of something that we do out of the goodness of our hearts, or using terms like moral imperative, it isn't real. We have to look at the contracts in order to be binding. We have to be getting something. And that's something, that value that we're getting has to be equal to or greater than the value that we're giving in order for this to be binding, and even if it is binding, for it to be rational. No professional in their right mind is going to take their limited time and devote it to an idea that's altruistic without receiving anything in return. So to be very pragmatic, I mean, in a resource-constrained country, the value that you get from doing the simple bone marrow drive is seeing the immediate impact. I mean, $1 spent in Africa can produce immediate results, and you get that satisfaction. You don't get the same satisfaction if you spend $1 in a country where basic needs are met. So there's an attractiveness for health professionals who are drawn to low resource countries for seeing the value of their work. But that satisfaction has value. In order for that same idea to work in more developed countries like the United States, there has to be some other kind of incentive, some reason for doctors to want to enter into a social contract and be willing to sacrifice the opportunity cost of that time that they would spend in other venues.
Okay. I'm curious for reactions to this. Thoughts from Sally?
I applaud everything you said, and I just, one of the things I want to follow up on is that I think what's bubbling to the surface here is that the social contract that we've been talking about all day on many levels has really focused on the sort of the deliverers of care. And I think what we're starting to see really come to the surface is the receivers of care have a place in this social contract, and they have to also give something to get something, right? I mean, if we're going to have a contract with patients and providers, there's got to be a give and take on both of these. And I just, you know, where I am, I sit in an environment where 220,000 people have come together on a social networking site that's research-based, that's giving them something back that they can actually look at graphically and say, oh, that's how I'm doing today. Oh, that's how my treatments are working. Oh, this is what some other patient can tell me about, you know, how they're managing, what they're doing, because they're getting to the real place of it. They're talking about it in a real environment of where health experiences typically take place is not in the gaze of all of us. It's outside of our gaze. And we're not giving people the kinds of tools they need in order to be able to work with us on this social contract. So patients are finding their own way of doing that. And I think that we're starting to see that with, we saw that certainly with the experience with the bone marrow donation outside of this country, and we're seeing it in social networking. And I think it's an area, it's the word social's in there, so let's catch on to that. Patients are gonna seek that kind of opportunity in order to learn what they feel they need to learn in order to engage with us. Now, two other comments I just wanna make, and I wanna be really succinct about this. I heard a frequently mention that we need to educate patients. And then I heard health literacy. And I'm going to challenge you in this room. Let's flip that paradigm. I think many of us as clinicians need to be taught by patients. We need patient literacy. We need to understand their language and where they're coming from. So that starts to level the playing field on the social contract. We can't simply say, we're going to teach you what we do. We need to say back to them, teach me what you do to self-manage your care so I can better understand how I can fit it in your framework as well. So just, you know, every time you start thinking about us as a, sort of the transdisciplinary professional group, flip it around and say, can I apply that same thing in a social contract with the people who I'm going to be interacting with in terms of the services that we're going to be providing? And I think every time you challenge yourself on that, there's an aha moment. It's like, oh, wait a minute, I didn't think about it that way. So that's just my comment on patient education is not the answer. Giving patients the opportunity to tell us what they need in the words that they use, and then us having the literacy that we understand what they're trying to tell us, and put that into perspective of what I think Judith said, which is get into the community and figure out what the needs actually are.
Good time for just a couple more. So back here.
It was something that came up earlier today, and one of the things that I think is critical is when we were talking about limited resources. You know, we have a lot of places in the United States, in a lot of rural communities, where there are limited resources, and really by force of the situation, we have transdisciplinary practice frequently occurring, and it's also wrapped up within the community as well. So I think we need to be thinking in a broader perspective, because I think we continue to talk about from more of an urban perspective, instead of realizing that there's a tremendous wealth of opportunity if we just look beyond the sort of walls of the city. But the other thing that I wanted to mention, early on, we had a discussion about whether it's social contract, social compact, or social covenant. And I think particularly in our culture, we're always trying to find the right answer. And I'm wondering if it isn't all of the above. And I think that if we start looking at it in the larger perspective, and you think of vocation, which is close to calling, which is closer to covenant, and I just wonder if we're just sort of narrowing down something that really needs to be all of the above to be a fulfilled relationship, not only with other disciplines, but with our patients, families, and communities. I'd just like to put that out there, because I think we're forcing ourselves perhaps into a box that isn't always the box that is the only answer. I'd be interested in the panel's response.
You guys have any responses to this? Oh, sorry. Yeah, please.
There are certainly people who agree with you. The Royal College of Physicians of London, for example, talked about a moral contract and the word covenant and so forth. The advantage of social contract is that it's got a history, that people understand it. If you start talking about those other words, you're going to have to make it up. They also, the word covenant implies a one-way relationship. And frankly, we don't think that'll work in current society. It would have worked in a much more non-secular society with a whole bunch of agreed upon rules and so forth. You know, Fred Hafferty did some work with Minnesota students, asking them if they thought they were going in, what they were going to do was a job or a calling. These were people from rural Minnesota, where you would have thought that the level of idealism was high. I can't remember your percentages, Fred, but it was about 80% job. So if we're going to influence behaviors by the words we're going to use, we think that social contract works a lot better, because it links it with a legitimate philosophical and theoretical background, and it implies reciprocity, that we have to act in a certain way, because if we don't, there will be consequences.
Oh, yes, Marla.
Sorry, I just want to respond that in this instance, it may be that there are disciplinary historical differences. And in the case of nursing, for example, there actually is a covenant base that reaches into mission, et cetera. So I think drawing from the cultural disciplinary differences as well as the global differences would be really important in coming to a final answer on that one.
Well, I had the privilege of spending time with Sunny on the planning of this program, and I'm also wanted to say I'm an educator, and notice with surprise that a lot of students seem to be angry and frustrated with their education. And my question to you folks is, do you think that frustration is because there's something that you're seeing that we're not, in the way that we're presenting these ideas or not presenting, that is there's some root of your frustration, and I'm being very I'm categorizing everybody in one box, and I don't mean to do that, but I suspect there are many of my colleagues that would say they have observed the same thing.
All right, we
Any
have
thoughts about that?
2 minutes for responses.
Yeah.
Yeah, student response.
My name is Grace.
Are you going to respond to the question too?
I'm a student at the university, a doctoral student at the University of Pennsylvania School of Nursing, and in my experience as a student at a bachelor's institution for nursing, one of the challenges I faced was actually interacting with other health professionals. We did learn in silos, and I thought that, you know, looking back, it would be nice to work with medical students. One of the big differences I see in terms of education is where we are. So for nursing education, a registered nurse, our training kind of ends at the bachelor's level, whereas for a doctor, they start really at the graduate level in medical school. And so it would be nice to kind of do things with them or have some sort of curriculum or at least a class where we took something together, or at least in each other's schools. And then for me as a nurse, a new nurse in practice, I'm just going to echo what was said before in terms of the difference in what we learn in school and then working. And so I did have the pleasure of working in a place where it was magnet, and we did kind of try to embody some of the things that we're talking about here, but there is a large variability in moving from different institutions and different types of institutions, so from a hospital to a nursing home, and then within different nursing homes. And that is incredibly frustrating. And for me, when I started as a new nurse, it almost drove me to want to quit, because it was just very shocking to not really even interact with doctors. We didn't round together. There was no communication at all. And even when you ask the why questions, to have things said to you like, because I said so. And so that's very frustrating. And so I think that if we could work on that, just not just trying to have the students come together in terms of like student body types of things, but actual curricular activities that are mandated and more cohesive, that would be very helpful. And then trying to decrease the variability in institutions afterwards when we are in practice.
Well, I think an affirmation that much more work must be done. But I actually am a little hopeful, because I think, I was talking with some of these folks, and I know some of these folks, I actually think there's an opportunity here for a slime mold moment for the senior generation, for government folks, and for the next generation to come together. In a way, I mean, it's represented in this room where you have some of the most senior leaders at the IOM, some of the most leading visionaries in health, and some folks who just finished their bachelor's in nursing. And I think that's a very important coalition, and it includes patients too, which is very key. So I'll turn the floor over. I just want to thank the panel for their candor. And turn over to Patricia.
And I'd like to thank Sunny for leading a great roundtable discussion. There's an old saying that art is long and life is short. So today was very long, but tomorrow's very short. So we ask that everybody please show up on time, 8 a.m. Breakfast will begin at 7:45 for those who want to have it before the whole thing starts. And one last announcement, could I have all the people that are going to be presenting at tomorrow's 8 a.m. roundtable gather up here around the podium? Thanks, everybody. I'll see you tomorrow.